Welcome to the lecture on the rotator cuff muscles. There are four rotator cuff muscles that all act upon the glenohumeral joint. These muscles provide significant stability to the glenohumeral joint and reinforce the joint capsule by having a common fused tendon. These muscles include the supraspinatus, infraspinatus, teres minor, and subscapularis. The supraspinatus is attached to the supraspinous fossa of the scapula and courses laterally under the acromion process to attach to the greater tubercle of the humerus. The primary movement of the supraspinatus is glenohumeral joint abduction from a neutral position. What I mean by from a neutral position is that the humerus is not internally or externally rotated in any way. The supraspinatus also functions to compress the humeral head, the glenoid fossa, providing stability to the glenohumeral joint. The innervation of the supraspinatus muscle is the suprascapular nerve. Take this opportunity to pause the lecture and fill in the muscle attachments as well as the muscle. How does your drawing compare? The infraspinatus is attached to the infraspinous fossa of the scapula and courses laterally and is attached to the greater tubercle of the humerus. The primary movement of the infraspinatus is external rotation of the glenohumeral joint. The infraspinatus also provides inferior translation of the humeral head in the glenoid fossa, again to provide stability of the glenohumeral joint. The innervation of the infraspinatus is the suprascapular nerve. Take this opportunity to pause the lecture to draw in the infraspinatus muscle attachments and muscle. How does your drawing compare? Teres minor is attached to the lateral border of the scapula and the greater tubercle of the humerus. Teres minor's primary movement at the glenohumeral joint is external rotation. It also provides inferior translation of the humeral head in the glenoid fossa for stability. There is controversy whether the teres minor actually produces adduction at the glenohumeral joint. Teres minor's innervation is the axillary nerve. Take this opportunity to label the muscle's attachments and draw in the muscle. How does your drawing compare? Subscapularis's attachments are the subscapular fossa of the scapula, which is the anterior portion of the scapula, and the lesser tubercle of the humerus. Subscapularis's primary movement at the glenohumeral joint is internal rotation. Like the teres minor and the infraspinatus, subscapularis also provides inferior translation of the humeral head in the glenoid fossa. Note that the subscapularis is innervated by two nerves, the upper subscapular nerve and the lower subscapular nerve. Take this opportunity to pause the lecture to draw in and label the muscle and its attachments. How does your drawing compare? This drawing is to help you understand the movements of the rotator cuff muscles. So the circle is representing the head of the humerus. The rectangle outlined in black represents the scapula with the glenoid fossa articulating with the humeral head. The muscles in red would represent the subscapularis. The muscles in blue would represent the infraspinatus and teres minor muscles, whereas the muscle in green is representing the supraspinatus muscle. The muscles in red, or the muscle in red, the subscapularis, its muscle fibers lie anterior to the vertical axis, therefore would cause internal rotation of the glenohumeral joint. The muscles in blue, the infraspinatus and the teres minor, lie posterior to the vertical axis, therefore would produce external rotation of the glenohumeral joint. The green fibers representing the supraspinatus muscle, these fibers lie superior to the AP axis, therefore would produce glenohumeral joint abduction. The rotator cuff plays an important role in providing stability to the glenohumeral joint. The joint tends to be unstable because, first of all, it is a ball and socket joint with free movement, and the head of the humerus is much larger than the glenoid fossa. The joint capsule that surrounds the glenohumeral joint is also thin, with most of the weakness located in the anterior inferior direction. The tendons of the rotator cuff converge to form a cuff over the joint capsule, which strengthens it. The tendon actually inserts into the joint capsule to help with the stability and to reinforce the joint capsule. So damage to the muscle or the rotator cuff leads to loss of glenohumeral joint stability. The head of the humerus is maintained in the glenoid fossa by a combination of the rotator cuff preventing lateral displacement and the oblique orientation of the glenoid fossa. As mentioned earlier, the shoulder tends to be most weak in the anterior inferior direction. The glenoid fossa is oriented in a posterior superior direction, which helps to maintain the humeral head glenoid fossa. Previously, we had mentioned that the subscapularis, infraspinatus, and teres minor provide an inferior translation of the humeral head. This is important when it comes to providing stability while the shoulder is actually moving. During the first initial 60 degrees of abduction, the deltoid produces a force that moves the humeral head in a cranial direction. The rotator cuff muscles produce this inferior translation, which couples with the force of the deltoid to keep the glenoid, or the head of the humerus, in the glenoid fossa. In other words, the rotator cuff and the deltoid produce a force couple so that the humeral head does not migrate cranially. Now I'd like to cover some pathologies of the rotator cuff. The first one is suprascapular nerve entrapment. This is typically caused by trauma and stretching of the suprascapular nerve. The suprascapular nerve innervates the supraspinatus and the infraspinatus. The nerve reaches this muscle these muscles by coursing through the suprascapular notch. There's a ligament that is over the top of the notch that forms the orifice for the suprascapular nerve to course through. This ligament is called the superior transverse scapular ligament. The suprascapular nerve passes under this ligament, prior to innervating the supraspinatus and infraspinatus. The suprascapular artery passes over the top of this ligament. So during trauma, if this nerve swells, it can become entrapped within the suprascapular notch. Another place where the suprascapular nerve can become entrapped is at the spinal glenoid notch. This is the notch that is on the lateral end of the spine of the scapula. Both the artery and the nerve course around the spinal glenoid notch to innervate the infraspinatus. In about 50% of the people, there's also a connective tissue band that covers the spinal glenoid notch where the nerve passes through. So to review the course of the suprascapular nerve, it comes through the suprascapular notch under the superior transverse scapular ligament. It innervates the supraspinatus muscle, then continues to pass around the lateral end of the spine of the scapula through the spinal glenoid notch to further innervate the infraspinatus muscle. Take this opportunity now to pause the lecture to draw in the superior transverse scapular ligament and the suprascapular nerve as it innervates the supraspinatus muscle, courses around the lateral portion of the acromion, and then to innervate the infraspinatus muscle. How does your drawing compare? Now I'd like you to think about the following questions. If nerve entrapment occurs at the suprascapular notch, which muscles will be affected? Which motions will be weak or lost? And which motions will be normal? If the injury occurs at the spine of the scapula, which muscles will be affected? Which motions will be weak or lost? And which motions will be normal? Shoulder dislocations is another pathology that can damage the rotator cuff. In particular, tears of the subscapularis can occur because when shoulder dislocations occur, they typically occur in the anterior inner direction. This again is due because of this being the weakest part of the joint capsule. If there's damage to the rotator cuff or weakness of the rotator cuff, this causes instability of the shoulder joint with movement, which in turn can cause impingement of the rotator cuff. The tendon and the bursa become impinged between the acromion process and the greater tubercle of the humerus. Rotator cuff impingement tends to be more common in individuals that have a shaped acromion process. Rotator cuff impingement is most often due to overuse and inflammation of the tendon and bursa. Rotator cuff tears can actually occur in any of the four muscles, but it is most commonly seen in the supraspinatus tendon. This is because there's actually a zone of hypovascularity within the supraspinatus tendon right underneath the acromion process. Those individuals with an abnormally shaped acromion process are at greater risk to develop a rotator cuff tear. Common causes of rotator cuff tears include high velocity trauma, such as in baseball players, when the arm is abducted and externally rotated, or overuse and degeneration, such as in wheelchair athletes who are often, well, always using their upper extremities, swimmers, and then those that do repetitive overhead activities. Rotator cuff tears lead to loss of glenohumeral joint stability, resulting in an unstable shoulder.